What I'd like to talk about today is a couple of things. The first thing is what I am. I'm an ordinary physician who absolutely adores investigating patients. It's the greatest game in town. It's the most interesting game. And ME and CFS, and they're not the same, are quite amazing areas to research because these people have so much pathology. And to understand ME, to understand CFS, you essentially have to understand medicine. And so the patients have been with primarily British physicians have been my teachers, and I thank you all. Well, the reason we named Florence Nightingale and took her name as our foundation in 1988 was she fell ill during the Crimean War. She was never a nurse, by the way. She was a hospital administrator. She was administered the British medical system during the war, or during the Crimean War, and she started the first bank for soldiers, and actually won amazing love from the English public, because up to that time they paid the military in the field, and they spent it on prostitutes and gambling, and nothing went back to the wives and children. So she set up a banking system where the money went back to the wife and children. So, but the main reason is she was bedridden for most of the time after she came back. And she reorganized not only the British medical system, the way the hospitals work, and the German military system, the sewer system in Calcutta. I mean, she was an amazing woman. She did it all from her bed. And I named Nightingale after her because life is very, very, very short. And I don't care how ill you are, how disabled you are, you have to make use of every minute, because this is a wonderful world, no matter if you ache, whether you're addled, whether you can't think straight, when you can't stand. You've got to make use of every minute in the best way you can and enjoy it. Get in trouble as much as you can, but enjoy life. The reason we use the tiger, this is Beryl Cook's tiger in Kew Garden. We use it because the first indication that there was something wrong with ME patients was that they had abnormal natural killer cells. And if you know what a natural killer cell looks like, if I can be so, what is the word? Nasty. It looks like a bit of snot. So it's not a good natural killer. So we use this as the natural killer. So this was the first physical entity that physicians were able to say was absolutely abnormal with ME patients. I do not think that ME and CFS are the same. I think they're totally different. And that's why I did this little red booklet. And I have to apologize to everyone because I finished this on Sunday night just before I left, had it printed up Monday morning. And I failed grade 8, 9, 10, 11, 12, and 13 in Canada because I could never spell correctly. I could never write a sentence correctly. It didn't seem very important to me at the time. And so this is me with all my errors, but it will tell the story. This is the difference between ME and the difference between what the Americans, with great deal of, how would you say it, imagination, invented this thing called chronic fatigue syndrome. Also, I do not believe fatigue has anything to do with ME. Every one of us, ill or not ill, get fatigued once a day, and we go to bed and go to sleep. Every major illness pretty well causes fatigue syndrome sometime. It doesn't help us to use the term fatigue. There is only one diagnostic criteria for ME, and that was the same at the beginning, and it's the same today, and that is brain dysfunction. And the main thing is what kind of brain dysfunction. All of the MEs in all of the epidemics, and you have to remember the first name of ME was epidemic myalgic encephalomyelitis. And what you have to think of is, number one, it was an acute onset disease. Number two, it was a diffuse injury of the central nervous system. Now, the central nervous system is the brain and the spinal cord. And we don't know much about the spinal cord until we really look at the autopsy material of the people with spinal cords, because we don't have any good technological instruments to measure the spinal cord dysfunction the way we would like to measure it. But we have lots of instruments to measure the brain. And I'm thinking of simple things like transcranial Dopplers. Cost nothing, gives you enormous amount of information. Top grade SPECT scans, which can look at the physiology and the pathophysiology of the brain. PET scans, which are less common, and you can get further down into the brain stem and in the posterior chamber of the brain. So for me, when people say we don't know how to measure it, that's the whole basis of what ME is. ME is acute onset, diffuse injury of the central nervous system, which is measurable. So much so, when we look at patients, and we look at both acute onset and gradual onset, if we cannot show persisting brain dysfunction, we don't call them ME. It's as simple as that. I call them CFS. So if you look seriously, say everyone in this room, and I know many of you do not have ME and many of you do, if I investigated every one of you, I'll tell you right now that at least half of the ME patients do not have ME. They do not have CFS. What they have is missed major medical disease. And the only way that you can get to the bottom of this is by actually taking a good history, and my history takes a day and a half, doing a good physical, and my physical takes 2 hours, and then subjecting poor people that fall into my prey 6 months of investigation. Now, most of the investigation I get done in Canada in 1 week, but then we repeat it in 6 months, and by then we've usually found out in many of the patients 10 or 15 things that aren't working with them. We send them off to appropriate specialists, and we gradually end up knowing a lot about these individuals. Sometimes we can help them, sometimes we can't. And I wrote this little pamphlet, really, and it's a first draft, so you have to excuse all the idiosyncrasies in it. But essentially, it is outlining my involvement with ME and my involvement with chronic fatigue syndrome and my interviews of McEvedy, who destroyed ME as a diagnostic criteria initially and made fun of it. And I do apologize to any psychiatrists that happen to be in the crowd, but one thing you should know about psychiatry, you can't test any of their theories. You cannot test any of their diagnostic criteria. It's not testable, and if you cannot test for disease, it doesn't exist in real terms. That doesn't mean the patient is not ill, but you have to distinguish between reality, which can convince every GP in the country and every internist and every specialist that a disease exists. And you're not going to do that by saying, I'm tired. You're not going to do that by saying, I'm dizzy if I stand up. If you've got a simple test, and we're down to that because we don't examine patients, most physicians anymore don't examine them. They don't get paid enough anymore as they did when I started. So they try to see as many patients as possible, and what they want to test. And it is so easy to test for ME people, because if they have a brain dysfunction and you can measure it, you've got a measurable test. And it starts only with there. And that has nothing to do with what I'm talking about today, but I wanted to start with that and have a good time with that little book. We were founded in 1988. I'd like to start with what I know best, and that's the patient. I told you I adore patients. And this is a patient that an incredibly terrible woman from England, Rosie Canny, sent me. She gets me into more trouble than almost half of the people I've ever met in this country. She asked me to see this young man. And shall we call him, I don't know what we'll call him right now, but he's 32 years old. He was 8 pounds, 8 ounces when he was born, a bouncing, healthy baby boy with a non-smoking mother. And he spent most of the first 22 years of his life having a hell of a lot of fun. I played football, cricket. When he was 21 years, he had his first significant illness. He had an encephalitic type infection, temperature of 104, double vision. He was minor upper respiratory tract infection or cold, but he was bedridden for 3 weeks, could hardly get out of bed. He had memory dysfunction. But then he got better, and he came back to 90%. At least he says it was 90%. Well, the next year, he started to piddle all the time. He was piddling during the night, he was piddling in the day, but he wasn't particularly ill. He went to the doctor, and there was no diabetes, there was no cystitis, and he then got his MA Environmental Sciences. So he doesn't have chronic fatigue syndrome, he doesn't have ME. He got a high-paid job in toxicology. He worked in Lake Baikal in Siberia, which is a wonderful place you want to go if you want to pick up toxic chemicals. He started having increased exhaustion, night sweats, low-grade cough. Didn't interfere much with his work. He had multiple sports traumas. Now, this is a guy who was interviewed for Chelsea and a couple of the other major football teams. He was good. And then he had, at the age of 30 years old, in 2003, his second major illness. And this is very important because a lot of ME patients have a history, and we discussed this in our textbook, 1992 textbook. They have preconditions, and there are many sets of preconditions. He had general muscle pain. He had severe global headaches. Now, he was earning, as far as I know, something like 80,000 pounds a year. He loved his job. This was a nifty guy. He loved playing football. He had a great girlfriend until he fell sick and she left him. But he gets all of these things, and you're beginning to recognize the muscle pain, the headaches, the myelitis, burning. Literally, myelitis is inflammation of the spinal cord from the occipital part of the skull right down to the lumbar spine, radiation of the pain, severe post-effort exhaustion, unable to stand up without dizziness and syncope, no improvement. So he got into this wonderful British assessment system, and he did it quite willingly. He went to one of these UK ME treatment centers, and he thought, they're going to fix me. Well, psychiatrist there in Manchester diagnosed him with depression, and they piled on all sorts of antidepressants, because as you know, all ME patients are really depressed. They're not really ill, but depression's a real illness. So the antidepressants made him a lot worse. So he had a big insurance policy because he was earning a lot of money. And so Unum carried the insurance. It's a company that exists in Canada as well as in England. And they sent him to psychiatrist Dr. David Gill. And you notice all the numbers and letters after his name: MA, MSc, BM, B chemistry, MRC, GP. I mean, he has to be knowledgeable because he's got all of these things. Here he is. That's on his website. My kids said nifty shades. Well, he knew because he was a psychiatrist. And my young man had the following diagnosis: chronic depressive disorder, obsessional personality traits, probably no physical illness, multiple psychosocial stressors, including work, relationship problems. Well, he didn't have a problem with the relationship, she left him. Impairment in reality, judgment, thinking, and mood. So we can't argue with this Dr. Gill, can we? Because that's what he's got. He's depressed. So he ordered very high dosage amitriptyline, clonazepam, and actually several other major antidepressive medications. He wanted him to go into psychiatric inpatient treatment away from his parents, who may be contributing to his depression and dependence, but above all, discourage him from thinking he had any physical disease. Stop any medication for reputed physical disease, since there's no evidence of physical disease. And I think this is the classical treatment of the psychiatric lobby in this country. And in our little red book, I pointed out that in the Oxford definition, which was the British definition, copycat definition of the 1988 Center for Disease Control definition, they thought they were going to get lots of money from the Americans. So they sort of piggybacked and gave a similar definition. 38% of the people who actually were on that definitional committee were psychiatry. They were all psychiatrists. I don't even think there was a psychologist, because maybe they didn't believe in psychology. But the point is, you can see where ME is going in the UK. It's going to a group where you can't test their theories. You can't test their diagnosis. There is no test for it. What was my history when I saw him? He had multiple sports trauma. He'd lost consciousness a few times playing football. He'd ran head-to-head with a few people and picked himself off the field a few minutes later and went back out. When I listened to his heart, he had post-infectious onset of tachycardia. His heart just went a mile a minute. He had the polyuria we mentioned. He still had headaches. His hands and feet were glacial. This is not a guy you want to marry. Always check out your prospective spouse, their feet and their hands. If they're too cold, you want to stay away from them. This is a guy to definitely stay away from, because he was freezing, the poor guy. Maybe that's why the girl left him. Pain and rapid exhaustion syndrome since onset. That doesn't tell us anything. What does is these cold hands. Now, he had a few other nice things. He had a hyperextensibility syndrome. Do you know what that is? How many people can take their thumb and touch their forearm? Try it right now. Stick up your hand if you can do that. The same people. Can you stick out your tongue and touch your nose? And don't laugh, neighbors, don't laugh at them now. Try it. Can you do it? Well, the third test I won't ask you to do, and that's to bend over and put your full palm on the ground. If you can do those three things, you don't have ME. If you can do two of those things, you may not have ME. What you probably have is hyperextensibility syndrome, and this normally is associated with flappy valves in the heart, and the main aorta wears out rapidly in the sense that it becomes too elastic too soon. And if you have those things, you should really have a complete cardiological workup. This guy had hyperextensibility syndrome. When I made him stand and I took his pressure lying down, sitting, and standing, it wasn't the same vehicle at all, totally different. He had what is called an incomplete Ehlers-Danlos-like syndrome. Now, this has the cardiac abnormalities. These people, I believe, have a gene for this, and it runs in family, Ehlers-Danlos syndrome. And I think it is probably a gene which is triggered by a virus. And these people look like Swedes. They have dolichocranial head, with the head which looks like it's been pressed here and extended this way. A typical Swedish head from an anthropological point of view. They have long fingers, long toes, and in fact, if you're a woman with this, all your toes are going to be like this. They're going to be screwed up like so. And so this is important. So look at your feet. I wouldn't take all your shoes off right now, but when you get home, check that out. If this is something you've got and you can do this, you should see a cardiologist. And there's various types of Ehlers-Danlos syndrome. The other problem that he had is this severe Raynaud's disease. So already we know that he's got an anomaly somewhere between the brain stem and the arteries in the body. Now, this isn't psychiatric. And one of the two people, Dr. Beard of the McEvedy-Beard group, who made such fun of the epidemic at the, I can never remember, is it London Free or Royal Free? Royal Free Hospitals. Beard was in court a couple of years ago and said to Dr. McPherson, quite proudly, "I don't examine patients." Well, psychiatrists in Canada, if they don't examine patients, the patient can sue them. Well, if you're a physician, you have to examine patients. He had another thing. He had hair between his belly button and his symphysis pubis. And in women, when you see this, they probably have polycystic ovary or a family history of it. He also, if you open up your mouth slowly, and it doesn't open up like this, but it opens up like a cow, you've got temporomandibular dysfunction. And that was mentioned today by one of the speakers. And again, this group of people, some of them have a problem because the entire structure of the mouth, you look at the mouth, the roof of the mouth can be arched. The teeth are too close together. And we've got a dentist in the crowd with an absolutely beautiful dress, and she was allowing me to examine her mouth today. And she had similar problems. Well, these people often can't sleep, and their jaw literally drops back and plugs their oral pharynx at nighttime. So we've got all of this in this person. Now, the other thing is he had a positive Romberg. Now, Romberg is very simple. You put the feet together, you shut the eye, and you feel like you're drunk, and you fall over. That's the first step. The second one, which I've never been able to do, I could never pass a white line test, is put one foot in front of the other and you can't stand. Well, I'm doing it now, but if I shut my eyes, I will fall. And so this normally suggests an injury to the posterior columns of the spine or the lower part of the brain, either the pons or the actual balance centers in the brain. He has all of these things. These are physical signs. I brought him to Canada because we had a hard time doing tests here. And his blood pressure was 80/40. Tilt table his heart went so fast, over 250, because our Doppler only measures up to 250 beats per minute. This is something seriously wrong with this guy's heart. And then his blood pressure fell when we stood him up, and he lost consciousness. We bring him down. We put him in a G suit. Those are great fun. Those are space suits, gamma suits. And he pumped it up, and he said, "Can I keep it?" Because he was fine as long as he was wearing a space suit. Be nice if we could get him up as an astronaut and keep him up there, because he would be perfectly healthy for a while anyway, until he escaped from that. So this guy has got severe heart-brain dysfunction. He didn't have it before he fell ill. The virus injury to his central nervous system did this. This is all measurable disease. We did some more tests in Canada. His thyroid was 5 cc's, 5 cubic centimeters in volume. Now, his TSH was 0.05 and normal is 0.3, so the thyroid stimulating hormone is the hormone that's produced in the brain, goes down and tells the thyroid what the hell it should be doing. Speed up if you need more energy, slow down if you got too much. So normal volume is 19 cc, average plus or minus 4.7. So he should have been between 14.9 and 24.3 cc's volume. Now that could have been checked here. All you do is you do an ultrasound. Now the interesting thing with ME patients, and we'll get onto this in the end, is you can do the TSH on most of these patients. You can do T3 and T4, and you can do microsomal antibodies, which is whether the thyroid is being attacked by itself. You can do parathyroid hormone, you can do calcium phosphate, it can all be normal. You do an ultrasound of the thyroid, and you can follow these people from the, and this is not all people because we haven't done it in all people, but you can follow a patient from the beginning of their illness and their thyroid shrinks. And we've got patients which the thyroid is actually shrink to less than a third of the size. Well, why didn't the TSH, T3, T4, and any of the other hormones change? We're obviously missing something that the thyroid does, and we don't have a test for it. You have to remember that TSH, when I started medicine centuries ago, didn't exist. It's a relatively new hormone they discovered about 35 years ago, 30 years ago. I think, I can never remember if it's T4, T3, I think it's T4, was just discovered 19 years ago. So there's a lot going on in the thyroid that we don't know. There's a lot going on in the base of the brain, which is making different parts of the body. But let's just stick with what we know. We already know that there's these abnormalities. Now that's the end of that patient. I wanted to start off with a patient to show you, here's a patient who has all sorts of pathologies. He had a GP in the town where he lives in Western England who believed in him, believed he was ill, protected him against his insurance company, but didn't know how to investigate him. Investigating anybody is the same. I don't care if you've been run over by a bull moose or if you've got ME or what you have. If you don't know, you test everything. And if a person has been ill for 6 months or 6 years, imagine what the government is losing on taxation alone. The real cost of investigating a patient is probably in Canada, with all of the tests we do and repeating, less than $5,000, which is £2,500. That's with MRIs, SPECT scans. That doesn't include PET scans because I have to ship poor people off to the States. But they don't mind because I send them to California for that. Now, I'd like to talk about ME and CFS. The public, most clinicians dislike the term chronic fatigue syndrome. Is there a difference? This is what ME is. It's acute onset. Gilliam says this, Wallace said it, Ramsey said it, Richardson says it. There's CNS, central nervous system dysfunction. There's a memory, cognitive, emotional, motor injury. These are acute onset. You know if it was acute onset. It's historical. You can't miss this. CNS dysfunction. We discussed some of the ways to measure CNS dysfunction. This is a measurable injury. Autonomic dysfunction. This is and this is, again, Gilliam said it in 1934, Wallace said it in 58, Ramsey said it with the epidemic here, and Richardson has been saying it ever since the day he was born till he died. Sleep dysfunction, this is a measurable quantity. You send them to sleep studies, and you can find out what type of sleep dysfunction they have. The pain, temperature, stamina, you can't measure that. Organ involvement, you can measure that. And many ME patients, as Richardson, Gilliam, and Wallace have mentioned in their write-ups on the epidemics, it's measurable. These are measurable things. So what is epidemic myalgic encephalomyelitis? Because that's how the name started. Acute onset of post-infectious autoimmune disease. primary physiological injury of the brain. Injury is always diffuse, and this is important because any neurologist can measure if you've got a bullet in your head, if you've had a stroke. I mean, your grandmother can do it. But a neurologist has an easy job with focal injuries of the central nervous system, whether they're MS or otherwise. If they're in the spinal cord or in the brain, you can tap the person on the knee, you can tickle them under their feet, you can make them stand like I just showed you, and you're a long way to saying what's going on to some degree. Diffuse injuries, you can't do that. You need technology. And there's lots of technology around, and there's a lot of really good people. So here we have an injury that disorganizes prior normal brain function, injures organ and system and life function. As in all illnesses, it can be variable. And what I've done in this little book, I've basically given you a one-page diagnostic criteria for ME. With all due respect to my colleague who did, to my way of thinking, an absolutely wonderful service to the ME and CFS community in doing the Canadian study, because it was the first time you actually had physicians who had seen an ME patient do a diagnostic criteria. First time. The London criteria, the Oxford criteria, there were some very good people and friends of mine on that, and who had actually seen patients, but the vast majority of those people had never examined an ME patient. The people in the 88 and the 92, if you look at the names and do a Google search or a PubMed search, had they ever written on ME or CFS before or after? The answer is no. They didn't know anything about what they were talking about. And so CFS is a, how do you pronounce the word? Chimeron? You know, this chimeron, good. You know, half eagle, half snake, half something else. It's a mixture. It's not a disease. It's not even a syndrome. It's a confusion between several different diseases, and they didn't know better. And they perpetuated that myth. And so this is another reason why in this little book I then give a different definition of chronic fatigue syndrome. And it's a very simplistic way, and it's certainly not the end point. But what I basically say is it's a gradual onset disease with missed major medical illness. So, and these people in general don't have brain dysfunction. Now, all brain dysfunction in ME patients are not infectious disease. We've seen them from recurrent trauma to the head. And possibly what happens is the blood-brain barrier is injured, and even a minor infection of no consequence gets in, causes this disease, or maybe it's just the trauma alone. We've seen a few people who've definitely had toxic chemical injury. Absolutely. Measuring toxic chemical injury for us in Canada is very difficult, because we can measure that they've got these toxic chemicals, but everyone does. What we can't do in Canada, unfortunately, is quantify how much until we have the brain and we do an autopsy assessment of it. So this is my brief diagnosis, and there's about the trauma. Some immunizations and their components can cause diffuse microvascular injury of the brain. And ME is essentially a diffuse microvascular injury of the central nervous system. You don't have to write all this down, it's in the red book here. Who says that? Dr. Ishmael Mena, 1988-89, when he was looking at these with Jay Goldstein. Dr. Eric Rill, who documented the Mercy Sacramento hospital epidemic and called it ME epidemic vasculitis. He was kicked off staff because giving a bad name to the hospital. Dr. Streeton, Dr. Bell, Dr. Peter Rowe of Johns Hopkins, vascular orthostatic pathophysiology, Dr. Vance Spence of Dundee in Scotland, says it's a choline esterase-mediated arterial dysfunction. There is no dispute about the people who've actually looked at this disease that you're dealing with a microvascular, and in some cases a macrovascular problem, particularly if they have some of these features that I mentioned, the hyperextensibility syndrome. Would you like to fall ill with ME? Now, if you'd like to fall ill, those of you out there that don't, this is how you do it. You choose a job with high exposure to repeat infections, such as healthcare and teaching. You repeatedly become severely exhausted. You work long hours. You do a lot of sports that give repeat head traumas at the same time, sufficient to injure the blood-brain barrier. And then you obtain any immunization you want and go to a third world country within the first 30 days of having that immunization. Or you can just go out and find yourself an epidemic disease of this. But I assure you, if you did all of these things consecutively, if you don't have ME, there's a good portion of you who will fall ill with ME. And I think this is important. Now, the immunization, many doctors don't realize, but there was a wonderful study done in the Lancet, I think in 1954, 55, 56, which looked at thousands of children in Wales, in England, and I believe in Scotland, and maybe in Ulster. I'm not certain about Ulster. And what they found was that it didn't matter what immunization you got. In the first 28 days after that immunization, you had an increased risk of falling ill with polio. And what was interesting is it didn't matter which month of the year, even though polio was primarily August, September, October, and November. It made no difference. Right across the spectrum, you had increased risk. And they found it was a bell curve. So around day 12 to 16, somewhere in there, that was when you were most susceptible to coming down with polio. So what happens if you want to get ME and you don't have it? You go to your doc and say, "Doc, I'm exhausted, I've been teaching too much, I've been working too hard. Shoot me up with everything you can because I'm going off to Mexico or Africa for a holiday." And doctor obligingly does that. You leave the next day, and then all of a sudden you encounter all of these lovely viruses and bacteria that your body has never seen before, and your immune system is shut down. And you pick up these things, and because your immune system is shut down, these nonsensical, ordinary, everyday viruses and bacteria can become chronic in your body and cause ME. And that's what ME is in many people. It's a chronic infection which the immune system is unable to handle. And I'm not saying don't get immunizations, but you should if you're going to third world countries, and especially if there's things like yellow fever for which there's absolutely no cure. But get them 30 days before you leave, and then you're going to be safe. That's probably what happened in part in the Gulf War. They were injecting people as they were getting on the plane. And then on this plane with all of these troops who are overtired from doing this exhaustive workup and getting into physical shape and getting rid of their 250-pound guts. And they're exhausted from that, they're shooting them up, and a few people are coughing. And maybe some of these Gulf War disease were simple, ordinary colds, which because the body didn't have an immune system that was functioning because of all of these injections, these became chronic and caused a lot of these problems. Who is at greatest risk? People in hospitals, schools, residential. This is the epidemics. When we did our study, the highest incidence was in pulmonary technicians in hospital. Now, there's not a lot of pulmonary technicians, but that was our highest incidence we found. And what is unusual about them? They work in a field where people come in coughing their bloody lungs up all day long. And so they're coughed up on all the time. And this is the biggest group. Now, they don't have increased anxiety. They don't have increased depression. They don't have increased psychological problem, what they have is increased exposure to infectious disease. And when we looked at the highest general number, it was primary school teachers with all these little kids that you want to strangle, coughing and doing all sorts of things all over them, and wiping their nose and wiping their bottoms and doing all sorts of wonderful things that teachers do. And hospital workers, particularly staffs in residential school for the mentally and physically handicapped. Those people live in a sea of germs because they cannot keep them as clean as in regular schools or regular hospital systems. So these people are not people who are more psychiatrically prone. What is the CC, chronic fatigue syndrome definition 88? It says basically, if you want to be nasty about that definition, if a physician finds anything wrong with the patient, abnormal tests, abnormal organ functions, major depressive disease, schizophrenia, dementias, then the patient doesn't have CFS. By exclusion, the CFS patient can only have an imaginary illness. Because if you can't find anything wrong, if you find anything wrong, they're excluded from the diagnosis, then you've got to have an imaginary illness, a psychoneurosis, a conversion. So the psychiatrists in this country are totally right. If you use that definition, the only possible answer is that these people have a psychiatric problem. That's why I hated the 88 definition. Now, what does the 92 and the 88 combine? Neuropsychological complaints, forgetfulness, irritability, confusion, inability to concentrate, memory, and everyone trucks these out as diagnostic criteria of ME and CFS. These are stupid criteria. These are the criteria for major depressive disease. Sleep disturbance and fatigue. If you limit your look at these things, and I'm in court all the time with patients, protecting them against the ravages of the insurance industry. And they say, look, they bring half a dozen psychiatrists and say, this is psychiatric, and we only insure for 2 years for psychiatric problems, so we want to cut these people off. So there's a good reason for the insurance industry and the psychiatric lobby to say this is psychiatric disease, because most people who do have disability insurance can be beautifully cut off by saying it's psychiatric. New topic. This is a study we did in 1992, and this is the age of the first illness. And starting at 3 years old, we're already seeing patients with it. And if you notice that the males have very low incidence, even at that time. Now, these are not ME, they're mixed ME and CFS. But you see the males don't really go up, but at puberty, the females go up. There obviously is some relationship with something girls do or something that happens in the puberty that makes the difference. Again, males don't really change much, but at somewhere around 30, you have this peak. And this is also when you have the teachers and healthcare workers who've got 2 or 3 little children at home and they're working all day, working at night. These women become exhausted. And they're doing 3 or 4 jobs at once. Any little virus, if you exhaust the person, the immune system doesn't work. This is why running, you see all these people jogging. These people actually are setting themselves up for all sorts of colds. They have a lot more colds and infections than the average people. I hate physical exercise personally. Now, we looked at the epidemic period of 1984. This is when I became interested in it. And it went up like this and came down again. It continued on after that, but huge numbers at that time. And at that particular period, what we did find was that in the Ontario government, the number of enteroviruses that went up alarmingly. Epstein-Barr virus didn't go up at all. When we look at by month across the year, again you have this peak here, and we weren't separating ME and CFS then. So a lot of the people underneath that could be people who had major missed major disease causing a fatigue syndrome. And so this jumping up, another jump up at Christmas when the same mothers or teachers are making Christmas dinner, all the family's coming, they don't sleep at night. People come from all over the place with their nice little new infections, and so you get another little jolt there. This was an epidemic of polio in New York City between 1911 and 1915. And I have to remind you that the first epidemic of polio, which occurred in 1889 in northern Sweden on the Norwegian-Swedish border, was called epidemic hysteria, mass hysteria. 12 people fell ill. And then in 1890 in Bergen and in Oslo, there were something like 10,000 went down with polio. The French then were calling it mass hysteria. These Vikings were just suffering from mass hysteria. So it started off like that until it hit France. Then it no longer was mass hysteria. Trigger factors. When we did our survey, 53 were infectious. 33% we couldn't find any cause. 5% was post-accident. And I was talking to Dr. Weir and Dr. Brostoff about this. We found in some motor vehicle accidents arterial blowouts in which an artery in the brain has literally burst. Mainly this occurs in women rather than men because the seat belts are adjusted in cars, most cars, for men. And so in the women, it comes right across the neck and right across underneath the chest. So when you have a rapid stop, it pushes this in. For an instant, the blood pressure may go up to 400 or 500 over 200. And if you don't have very elastic blood vessels, you've got a chance of bursting one of them. And you can pick this up, and we do routinely on the post-motor vehicle accident people by a simple transcranial Doppler. Family members who fell ill with ME, and it was very interesting when we look at just one person like this, 2 people like this, 3 people in the family, 4. So it happens that more than one person falls ill. But look at polio. This is ME, in the blue is polio, if I'm not, no, the red is the polio. Pretty well exactly the same curve. Another reason for thinking that at least during this epidemic period that we were surveying, were related to an enterovirus. Very similar profiles. Okay. And professional risk factors tells you all. Nurses, teachers, lab technicians. Bookkeepers. These people, if I was a bookkeeper, I would be ready to have my brains tied in knots. These are the people that should be having psychiatric problems. They don't. They have a negative amount of it. What you have is the people in high contact with infectious disease. I won't go into that. Maybe we'll stop here. I'll try to skip through this one because he's fun. All of these patients with ME are fun. 34 years old, had influenza immunization, November 2005. Within a few days, he gets classical ME. When I saw him, which was in January, he had Candida infection. Now, this is not, I got Candida kind of person. He had a white mouth and white tongue, like a newborn baby who's picked it up, and just this huge furry growth. You didn't need to test, but we sent him for tests, and it was Candida. We treated him. The Candida got better. He didn't get better. So we sent sputum for culture for bacteria. Now, we picked up a bug called Serratia marcescens. Now, what is important about that is this is produced by an American company who has a manufacturing facility, or had until this year, in the United Kingdom. And they produce influenza immunization for United States and Canada, and probably for UK, I don't know. It's the same company that produced recombinant hepatitis B immunization, which we've had so many severe problems with, and for which I was in court most of this year up to now, protecting my patients. Now, a nice thing to know about this bug, Serratia marcescens, it never existed as a human infection before. So the Americans, in their great scientific endeavors, decided to spray San Francisco and the subways of New York with this bacteria to test the effectiveness of their germ warfare measures. And they used this because this is the red, moldy stuff at the bottom of a dirty bathtub. If you've been away for vacation and you come back after a month and you look at your bathtub and you say, yuck, because it's got all this red scum on it, that's Serratia marcescens. And it somehow contaminated this factory, but it started with the Americans spraying it in these two cities. And it probably became endemic. The only trouble is that no antibiotic is very good at getting rid of it. So I told you all of this. Told you that. This guy's gone from 185 to 165 pounds since November. He's got all of the classic so-called ME symptoms. He's not getting better. And we can say for sure that this guy is ill because of a chronic infection and probably from this immunization. And if you want to Google this tonight or go into PubMed, you'll find with great difficulty, well, you find without any problem the Chiron, or Chiron, I believe you pronounce it, data. And you'll find a lot of data about marcescens, but I was only able to find two that put the two together. But it is out there. And so maybe, and I'm just not saying for sure because the evidence is rather weak, but maybe this type of thing is what causes a few people to have an ME-type syndrome. And I won't get into the ME. Well, there's only 2 slides, so I'll just do that. We looked at 176 ME patients. 51% of their thyroids were pathological. Most had atrophic thyroids, hypotrophic thyroids. 6% had malignancy, 18% had Hashimoto's thyroiditis, and 98% of them had normal blood. So doctors only do the blood. You have to do an ultrasound. And that's all.